This is the Emergency Medical Minute, sponsored by Health One.
I was going to do a medical minute on the use of peripheral vasopressors. A lot of times we have patients that need pressors for hypotension, and we initially consider starting those pressors through a peripheral IV and while we're waiting for a central line. And there's been a lot of controversy or discussion and studies looking at the potential risks and safety of doing peripheral vasopressors. The potential risks are that if the vasopressor extravasates into the soft tissue in the arm, you could have local ischemia, potentially skin necrosis, potentially limb ischemia, potentially pretty significant morbidity from the extravasation. So, studies have looked at this, and overall, it seems like the rate of vasopressor extravasation is not that high. Most studies say it's around 2 to 4% having any extravasation, and then of those, there's actually very few that had significant complications. Very few, really, if any, tend to need significant treatment. There's hardly been any cases of real limb ischemia, skin necrosis, anybody needing much surgery. Most times people don't even need medications. They just get observed if they have a little bit of skin necrosis or extravasation. The risks of central lines need to also be considered. There's complications from central lines, so they're not a completely benign procedure. So I do think that if somebody needs pressors and they have a good IV, it is reasonable to start them peripherally while we're either waiting to see if they improve with IV fluids or blood or other treatment, and then waiting until the central line can be inserted, and then switching over the pressors to the central line. If we do start peripheral pressors, which seems like a very safe and reasonable option, we should make sure that the IV is a good IV, ideally a larger size IV, and ideally something more proximal, not a small IV in the hand. And if we do start the pressors peripherally, that the site should be monitored for extravasation or any local effects. And as long as it is being observed and monitored, it's probably a safe practice. Most studies kind of recommend doing it for less than 4 hours until switching over to a central line if pressors are needed. Thank you very much.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.